Greetings. Our Chinese partner, how are you today? Can you hear me? Hello. Okay, you can hear me. Good morning, Yi. Hello, Yi, are you there? Oh. I'm trying to promote you. Hello, Yi. Hello, Yi. I'm trying to get you in here. Oh, decline. Yeah, Yi, you have to accept to be a panelist. Oh, you're not ready. Okay, you're probably not ready. All right. Oh, man. You Chen, you have to, you can't come in? Okay, you Chen. Okay, Yi, you have to enter. Yi, you're still not in the panel. You have to accept. Can you hear me, Yi?
Yeah, I'm in.
Oh, okay, okay.
I'm the first or the second.
Hello, Dr. Chen, how are you?
Hello, I'm first or the second speaker.
Yeah, your camera, you got your camera working there?
Yeah,
Okay, how are you doing?
fine.
Careful with opening the overhead compartment.
Dr. Shen, okay, Dr. Shen, you're giving the second talk, right?
Okay.
Okay, and Yi will introduce you. Do you know Yi? He's at the same hospital, right? Yi Liu? Yi, are you there? Lee keeps refusing to come in. Lee, are you gonna come in?
Hi, John. This is Yuan Li.
Okay, I can't
Actually,
see you. Where are you at there?
yeah. I'm still on the flight.
Oh,
So
there you
it's,
are. You're there.
It's
Okay.
just landing. So I think maybe you can just let Dr. Chen start his talk. I saw there's no Abdulrauf yet.
Oh, you want me to introduce the speakers?
Actually, yeah, you can. Because I'm still, I'm just landing. The flight
Oh.
did not stop yet, so I
Oh,
think I
okay.
should not talk too much.
Well, I'll see if you're ready, you can introduce them, okay?
Maybe, actually, yeah, I can do it. Dr.
Yeah,
Chen
yeah,
is,
well, let's see. I'll see when I'm ready
Okay.
to do it. If you're there, fine. If not, I'll go ahead. Okay, we're waiting for Dr. Hold on.
So is there any problem with Dr. Abdulrauf?
Yeah, I don't know what's going on here. I don't know what's going on with the link.
Maybe
Hold
we
on.
can wait.
Hold on. Yeah, I don't know what's going on.
few
Let
minutes.
me investigate, okay? Oh, man, oh, man, oh, man. Just give me 1 minute. Okay, okay. I know what to do.
John, so can we start with Dr. Chen's talk?
Yeah, let me just see if, yeah, okay, just give me a second. That's probably a good idea. Let me just, yeah. Hold on. Okay, I got a hold of, just give me 1 second. Okay, he's here now, okay. Can you introduce Salim? He's here now. You want to
Yeah,
introduce?
can.
Okay, I'll start right now. Are you ready? Do you want to
Actually,
introduce Salim?
I saw Dr. Abdulrauf. He's online, so maybe.
Yeah, he's here. He's here. Good day,
So-
Salim.
Hello.
Okay, we're gonna start right away. Okay, you ready? Ready, Lee? Hello?
Dr.
Okay,
John, can you just introduce Dr. Abdulrauf and let him start? Because I'm still on the fly.
Okay, no, I'll introduce him. Okay.
Yeah,
Here we
and I
go.
will-
10. Yeah, I'll do him. If you're around to do the second speaker, you can do that. Okay.
Yeah, sure, I can do that.
Okay. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett from Miami Beach, home of Neurosurgical TV. This is the bi-monthly China Neurosurgical Journal webcast. And today we're featuring Salim Abdulrauf, neurosurgeon that is the head of the Walter Dandy Society, a global organization, which does a lot of good for education around the world with young aspiring neurosurgeons. So right away, we'll introduce Salim. Good day, Salim, and thank you for connecting.
Great. Thank you. Thank you. It's my honor to be with you. It's my honor to be with our colleagues from China and around the world. I'm really pleased to be here today. So I'll go ahead and get started. There are a lot of highly respected bypass surgeons and vascular surgeons in China, and I'm really pleased to be part of this panel. I'll go ahead and yeah, so today I'd like to just discuss with you my evolution personally in bypass surgery. And I want to thank the professors who have invited me, Professor Zhao and Professor Ben Zhu, respected vascular neurosurgeons. Essentially, in this field, we stand on the shoulders of giants. Professor Yashigal had an impact on my career early on, and the first ECIC bypass surgery, SDMCA bypass in the late 1960s was done by him, and now we stand on the shoulders of such giants. Early on in my career, I was exposed to some cases that taught me lessons about how dangerous some of these lesions can be, and why bypass surgery or high flow bypass surgery had to develop. This is a patient I saw with this aneurysm that came in to us with the ophthalmoplegia, and we got an angiogram, and it was mostly as you could tell, this is a cavernous segment aneurysm, and we were contemplating what to do for this patient as we were looking at the angiogram and reviewing everything. And suddenly I was called that patient was fixed and dilated and expired. The patient died from this aneurysm, and the aneurysm was so large that it tore through the dura into the from the cavernous sinus into the brain, and the patient died from it. So this was an early lesson for me that these lesions are very, very dangerous when they're diagnosed, and that treatment had to evolve to help deal with them. So as I started to develop and start thinking after my fellowship about bypass surgery, I was confronted with some lesions that were very concerning, and I had to start thinking how to deal with some of these things. This is a patient who has both internal carotid arteries occluded here. The brachiocephalic trunk is occluded. The only artery that's supplying the brain is the right vertebral artery here. And the right vertebral artery goes to the brain, supplies the whole brain. And this patient, whenever she uses her left arm, the blood goes down to the arm from the brain, and she starts becoming ischemic, develops ischemic syndromes. So it's a very complex situation as to what to do in this thing. Both carotids are included. So there were a number of options that were given about doing a bypass here, bypass there, and so forth. But she's already very hypoperfused. There's not enough blood going to the brain. And then she's dealing in the retrograde flow into the vertebral artery going to the arm. She would not tolerate a craniotomy, because putting her to sleep with a craniotomy and try to do an anastomosis in the brain would be too dangerous for her. Okay. So I decided to do something very different, minimally invasive. Essentially, what I decided, with this occluded here, with the two internal carotid arteries occluded, with the blood going to the right arm, that we divert flow from here to here. That way we make the flow go anterograde to the vertebral artery instead of coming down here, so this flow will go up to the brain. So this is the kind of anastomosis we do with that. So this is the intraoperative view showing the blood is going this way, now is going through the graft this way, now going up to the brain. Okay, so this is kind of an early picture showing that a minimally invasive approach to reverse flow to the brain was helpful in this situation without doing a big operation, big bypass surgery, and so forth. So that's that's her. She's doing great on aspirin and doing well with that. Then as we developed more, you know, the standard bypass surgery, the STA, MCA bypass surgery, which is, of course, is a big experience in China with this procedure, okay, with Professor Zhu, that you do a lot of these procedures. So I started thinking, and this is essentially defined by Professor Yashigil in the late 1960s with a craniotomy. So early on, I decided to think, well, this is a pretty small procedure. We don't need a full craniotomy for this procedure. So I decided to use image guidance to identify the STA and then identify the recipient branch. So the donor and the recipient, right there, donor and recipient. And for that, all we need is just a tiny burr hole size opening. That's all we need. We don't need a craniotomy. Right there, 2 centimeters. And that's a bypass right there. See, that's the opening right there. So it does not, this is not a big procedure in the sense that you could just identify the donor and the recipient and do the bypass right there in a very, very small procedure. That's right there. We published this early on, showing that this does not require a craniotomy for a low flow STA, MCA bypass. For Moyamoya disease, you know, same procedure, EDAS or direct anastomosis. In this case, this was a young patient sent to me from Qatar who has no STA. So this is the occlusive disease. This is the middle meningeal artery here. No superficial temporal artery. So what do we do thinking outside the box? So this is a middle meningeal artery here. This is a middle meningeal artery here. And I attach the middle meningeal artery to the middle cerebral artery directly. So thinking outside the box, you could just use these bypasses directly to the brain and supply the brain with blood, even in using an artery like the middle meningeal artery in this case. Right there, middle meningeal artery in a patient who does not have an STA going to the M4 branch right there. That's him a few days later after surgery. So next we come to the idea of high flow bypass. And I want to talk to you about my evolution in there, okay? Early on, you know, we really found out that carotid occlusion that was being done for certain aneurysms, if they were large and there was no other option, in the long run, ICA ligation, occlusion of the carotid artery, carries quite a bit of a risk, even if patient tolerates temporary occlusion of the carotid artery. So pure occlusion of the carotid artery can carry quite a bit of a risk. So with the ICA sacrifice, we figured out that that would be a risky procedure, even in the long run, if the patient tolerates it upfront. So preservation of the large vessels was the idea that we started with. So after I came out of my fellowship, the early pioneers in high flow bypass were mostly using the saphenous vein graft. So I scrubbed in with some of the cardiac surgeons early on after my fellowship to see how they do their heart procedures. And they were starting to use quite a bit of the radial artery. Because the radial artery does not have valves in it, it has a good size match compared to the saphenous vein. Around that same time, Professor Shaker was also using the radial artery. So I started using the radial artery. This is, for example, is a giant aneurysm here. See coming off just distal to the anterior choroidal artery. And here we use the radial artery for the now giant aneurysms, we published this early on, showing how the radial artery is a better conduit than a saphenous vein graft. So as we were doing our early bypass courses in the United States to do ECIC bypass procedures, neurosurgeons from around the world would join us for these courses. I really pushed the idea of using the radial artery graft, and it is being used by majority of vascular neurosurgeons now from that perspective. Now the idea came is how to make this bypass better. So I was thinking, since this procedure requires a big incision in the neck, in the arm, in the head, is how can we make it a bit better from that perspective and less invasive. So the way the procedure is done now, you go to the neck, long incision, and go all the way up here to here. Okay, so it's a very long graft, and in the arm, it's a long incision to take this graft out. So I started to think, because I'm a skull-based surgeon, and I used to run into the maxillary artery, which sits right here, is why not go from here to here versus all the way from here to here, and you don't need as long as a graft. Perhaps the most important thing is, as a principle in high flow bypass, the longer the graft, the higher risk of occlusion. The shorter the graft, the better success rate. So I started to work on the concept of using the maxillary artery to the middle cerebral artery bypass. So this was the idea that emerged at that time. And this is from the cover page of Neurosurgery Journal, where we describe this technique. I'm honored that many neurosurgeons call it the Abdulrauf bypass. I'm honored by that. So essentially what it is that this is the maxillary artery here. Instead of going all the way to the neck, we go from here to here. That's it. Instead of going all the way from the neck. So this was our early work, anatomic work, identifying the maxillary artery in the middle fossa, extradurally, anatomic work that I did. And this was the first case ever published, first clinical case after we had IRB approval, to these procedures, to do the, this was the first case. See, so these are the, essentially, this is the extradural approach in the middle fossa, identifying the maxillary artery, and then attaching that to the middle cerebral artery here. Okay, so that's a bypass right there instead of going all the way to the neck. This is another procedure. That's the maxillary artery right here. Okay, and then that then goes to the anastomosis here. Let's show you. So that's the maxillary artery. In this case, because we now can use the whole length of the radial artery, in this case, the patient needed 2 anastomosis. It was a giant aneurysm. If you go all the way to the neck, you don't need to have a long enough radial artery. But in this case, I cut a portion of radial artery, attach it to the side, okay? And here, attach the side of it here. And now we have 2 anastomoses we could do to the brain instead of just 1. And now continue the procedure. So that's the difference, going all the way from here to the brain, a standard high flow bypass versus going from here to here. Okay. So that's really the difference that we have made from that standpoint. This is from Professor Spessler's book, bypass book. He identified this. I'm honored for it to be named after me. Okay. And this is a bypass that we talked about. And also over time, as I evolved in bypass surgery, we started thinking about instrumentation. We needed longer instruments, bayoneted instruments. For example, this is a case of a complex basilar tip aneurysm. Let me show you here. So we're deep here around the brainstem, around the midbrain. This is a PCA. So the instruments we had to develop had to be longer and bayoneted to go all the way down around the brainstem to be able to do these anastomosis deep, putting this radial artery. So as a disclosure, I worked with the Scanlon company to develop long and bayoneted instruments that allow us to get deep and all the way around to be able to handle these kind of anastomosis in deep locations. And that's, as you see, we're doing the deep anastomosis here. There. See, that's it there. This has to look like an elephant foot. And that's what you're looking at here. And that's a running stitch that we do. So that's creating, so that's all the way creating, this patient had a coiled aneurysm that bled, and the P1 is incorporated in it. So we had to create this bypass to the PCA so we could occlude this P1 here. So next emerge, so this is just evolution, the way I've been thinking about it. Next emerged the issue of Moya disease patients, especially because they have such restricted blood flow to the brain. When you put them under general anesthesia, what happens, they can have periods of hypoperfusion because of the vasoconstriction from hyperventilation that can occur intermittently. These patients are so ischemic that could be risky for them. So I was sent this patient by a colleague in the United States who did a procedure for Moya, everything went fine, and the patient developed a big stroke after surgery. And after everything was reviewed, everything worked, everything was perfect. They ended up doing a big craniectomy here. It was due to the fact that the CO2 drop, the patient was so sensitive that led to a stroke in this patient. Everything went perfect in the surgery that he did. We reviewed everything, right? So we started to think, what else can we add to bypass surgery as we evolve? What is the missing link? What is the problem in bypass surgery that for complex cases, whether it's high flow bypass for aneurysms or whether it is a Moya disease, is there something else we can add that can make things better? So let me explain this to you by showing you a case here and tell you why that is. So this is adding this missing link, which I call the awake part, okay? But let's take one thing at a time. So we identify the maxillary artery, okay, right here, fine. And that's a maxillary artery here, right there. And now we harvest the radial artery graft. We harvest. Inflating it, make sure there are no big holes. That's a radial artery here. At the same time, by inflating it, it's running down to now I'm attaching the radial artery to the maxillary artery, which is not a problem because the maxillary artery does not supply the brain, okay? Now you see nice flow from the maxillary artery, great. So how does the awake help? There are two, I already explained to you, the awake helps in Moya Moya because
Sorry, I'm having
in Moya Moya because of the potential hypoperfusion. But how does it help here? So essentially, this is a middle cerebral artery here. So there are two places where the awake makes a huge difference. In standard general anesthesia, we would put temporary clips and we would do a temporary clips and we would do anastomosis here. We're relying on EEG and SSEP to know that there is no problem going on. But the problem is these have false positives and negatives. So how are we gonna know if the patient can tolerate long enough time for this M2, M3 division to tolerate temporary occlusion? We don't know 100% for sure. So the patient can develop a stroke just from temporary occlusion. So what we are gonna do here is I'm going to put a temporary clip, and then we are going to test the patient.
Lift her hand.
So essentially what we do is test if the patient can tolerate the occlusion of that division. What we found from our experience that patients can tolerate occlusion of one M3, but not the other one. And we don't know that under general anesthesia because one M3 may have better collateral. By doing this, we know right away.
Sarah, squeeze my hand. Perfect. Let go.
So if you do this test, and we found out if you can tolerate up to 3 or 5 minutes, and that's a range, then you can tolerate the whole length of the thing based on our data that's coming out, okay? So now we're gonna go ahead and anastomose to this M3 without worrying while we're talking to the patient, okay? So that's the important thing that the awake makes a difference in. Now, so we have a nice bypass here, okay? Next, what is number 2? What is the other factor? Under general anesthesia, after we do our bypass, we go ahead and occlude our internal carotid artery, and we pray that everything is fine. But how do you know for sure that your graft is 100% working? For example, all these patients have failed balloon test occlusion beforehand. How do you know 100% for sure that that graft is working and everything is going to be okay? You're basing that on their general anesthesia on factors you cannot know 100%. That's why there is a reasonably high stroke rate and high flow bypass surgery. So how are we going to avoid that? Okay, we're going to temporarily occlude the internal carotid artery and test the patient for 10 minutes with a hypotensive challenge to make sure our graft is supplying enough blood without any risk of problem. Okay, so this is what we're going to do. So that's 10 minutes temporary occlusion. Okay.
Sarah, squeeze my hand again. Sarah, squeeze my hand real tight. All right, let go. Let go. Perfect. Good job. Look at your toes. Look at your toes.
Great.
Great job.
So you see 10 minutes temporary occlusion, then permanent occlusion. So we know the results of the procedure before we leave the room and not take a risk of a post-operative problem. Okay, so that's really the showing you this bypass, knowing upfront how we can reverse potential risks to the patient before we do anything. John, how much time do I have?
About 15 more minutes.
Okay. So, you know, I compared my own results to my own results with awake surgery for high flow bypass. in my own hands, you will see we improved the graft patency in my own hands. We changed the whole outcome based on switching to awake surgery because we're able to test for the factors that I just explained to you. And you could look these up. This is all published data. So we have published this data to show what outcomes we have. So that really brings us to the how. So I took you stepwise, beginning with the revascularization in the neck. Then our work in STMCA bypass, then our work in high flow bypass, and all the points that we have raised with you here. We are currently involved in a multi-center trial to look at, specifically to look at the awake portion of the procedure, okay? This, at the primary center, when we started this procedure, the consent for the patient for the awake that I talked to you about requires 4 levels of consent to make sure that, for these procedures, that the patient is fully consulted and has had the consent for it. And this is the same status that's being used for our multi-center trial at this point. So the first phase 1 of this trial was from 2013 to 2019, okay? This was for complex aneurysms and AVMs, the kind of aneurysms I just showed you. The contraindications where the patient is declining the option or the anesthesiologist feels that that procedure is not, they don't feel their airway is comfortable, okay? So this procedure for this multi-center study we're in now is only approved for, and I need to explain that to you, for complex, since we're talking about aneurysms only, not simple aneurysms, okay? The reason is that our committee that looked at this said the outcome for simple aneurysms is already good in the literature, but for complex aneurysms, which are calcified, partially thrombosed, previously coiled plus stented, giant or large, for these set of aneurysms, the outcomes are not so good. So the committee felt that if we can show a better outcome in these cases, then it can be applied to other cases as well, okay? So this is why the study only includes the complex cases. So this was from phase 1, from my own personal review by the committee, and I'll show you all the data here in a minute, but essentially this was, the phase 1 had 202 patients, 162 underwent awake surgery, and 40 patients refused awake. And this is the committee looked at, this is through electronic health record review. The committee does, this is not done by neurosurgery. This is done by the committees that look at your electronic health record, look at every patient. This is patient identifying factors, morbidity, and mortality. So everything else is covered up with this patient's private data, okay? And these are the 40 patients that turned down the awake option for these complex cases. Same thing. So for phase 1, we are now actually at phase 3 of this procedure, of this study. But for phase 1, for complex aneurysms in grade 3 and above AVMs, what we saw here is a significant change in outcome of patients. So, and this included all the high flow bypasses. So we went from morbidity of 10% to 4.3%, mortality 2.5% to 1.8%. For the literature neurosurgery for complex aneurysms, AVMs, these are some of the best results there are. So it appears that the adding of the awake element and testing the patient has had a significant difference. And this data is going to be coming out in a lot of papers in the next few months, has had a significant difference and outcome of patients. This same team, same surgeons. So now we're actually in the multi-center aspect of the study with multiple centers involved. So this was the last element that we added in our journey through high flow bypass and going through that. And as far as high flow bypass is concerned, you know, it's been something, or bypass in general, something that you know, I've spent much of my career on. This book, my book on severe revascularization, you know, is used as a reference textbook by many centers. For the young neurosurgeons who are watching this, this book has all the technical elements that you need for the kind of bypass procedures we're talking about. So I wanted to end with this slide. And I just wanted to say we're doing a big bypass course in Washington, D.C. in July. For those of you who are interested from that perspective. I want to acknowledge Professors Ben Zhou, who's you know, one of the most respected you know, neurosurgeons that are doing bypass surgery. Professor Zhao from Tiantan, you know, for being here and for the kind of work that's being done in China as well in vascular neurosurgery. I think I want to, you know, I think to respect the time, I probably want to just stop there with what I showed, and I'll leave the professors to add their comments as well.
Thank you very much, Celine. And I apologize. I sent the incorrect link out to Ben. Okay, Ben. Welcome and welcome. It's your
hello, Professor Stein. Thank you for your nice presentation.
Thank you.
Actually, I missed your one of your part. I tried to log on, but it's a wrong link. So you know.
Oh, sorry.
Very nice. I think, but do you really think that the awake bypass plays some have some special advantage comparing the general anesthesia?
Yeah, so essentially, I think it has to do with the temporary clipping time.
Mm-hmm.
For the SDMCA bypass, in general, would not make that kind of difference. But for high flow bypass, if you're occluding the M2, M3, how long the patient can tolerate that occlusion becomes a big issue. And secondly, when you occlude the carotid artery, to do the temporary occlusion first under awake testing, then occluding it, our data shows it makes a difference for sure in our perspective. And for Moyamoya disease, for SDMCA bypass, the awake avoids the hyperventilation at any point, because in awake, the patient is hypoventilated. So the CO2 is high. So those are the elements in bypass surgery, I think, that can make a difference for sure.
Okay. Actually, I always use general anesthesia, and I know your concern, because according to the course trial, the mean, the average temporal occlusion time of the recipient artery was more than 15 minutes.
I know.
So it's quite long. But
yes,
I think maybe for the long time, temporal occlusion is helpful. Thank you.
Thank you.
Because you know, my mean temporal occlusion time was less than average 13 minutes.
Nice.
So I never use
yes.
Very awaken, and yeah.
Well, you're very experienced, so your experience speaks for itself.
But I think one thing is important, that in some, I still think the M1 giant aneurysm have some very crucial perforators involved in the aneurysm door, was still the most difficult ones.
Yes.
because after maybe intraoperatively, it's still functioning the perforators, but after the temporal clip or some trapping of the dome maybe cause some late stroke.
Yes.
Even a small stroke
Yes.
can cause a hemoparalysis.
Yes. Yes.
Yes.
One of the things, Professor, for the awake, what I found for perforators is a very important issue. So under general anesthesia, you put multiple clips or whatever around perforator. The
Yes.
guy doing under general anesthesia, the EGSSCP, they're telling me it's okay. But the patient may wake up with a problem with the
Yes.
perforator. In awake,
Yes.
what happens,
Yes.
you put your clips on, and you know right away with the awake testing, because it's 100%. Then you
Yes.
reconstruct your clip. So I have found the awake with perforators is so helpful, is more helpful than the electrophysiology. So there are these little things that add up at the end of the day. So these
Yes.
are the little things. And I understand this is something new. I respect neurosurgeons around the world, but I'm just showing our outcomes and how I have evolved. And, for the awake, it needs people very experienced like yourself, Professor Zhu, because I could not have done awake high flow bypass and AVMs early in my career. No way. It's only when you have a lot of experience that you get to a point where you can feel, so slowly I'm introducing to the literature, and then experienced neurosurgeons can decide for themselves as to what's best from their standpoint.
Yes, I think maybe the awake operation may be helpful in treating the M1 or M2 segment and giant aneurysms.
Yes, yes.
Thank
I
you.
look forward to collaborating with you, Professor
Okay.
Benzu, in the future, both in teaching and clinically in the future. So we will
Okay,
stay.
great.
Yeah.
Okay,
Thank you.
thank you.
Okay, once again, I apologize, Ben, for the bad link. Okay,
It's okay. It's okay.
now Harshad Parekh, he's a regular at this webcast. He's going to fill in as the moderator for the more questions. He's a neurosurgeon from Mumbai. Welcome, Harshad.
Thank you. Thank you, Professor Rauf. Wonderful talk. I've been a regular in listening to you in various webinar and webcasts. And wonderful journey you have shown for your bypass techniques. And I've heard you for the awake craniotomies, for the aneurysm clipping, and that was very surprising to me. And you have produced some wonderful results in past. And you are a great fan of awake craniotomies. And yes, it is the way to look forward. Your results have shown that between awake and a general anesthesia, better in awake than in general anesthesia. And yes, we have seen this when we are monitoring under general anesthesia, when you put a clip and you find SSCP and everything is clear, and next time when patient wakes up with some kind of hemiparesis or some deficit, definitely we have seen. And it really works, but many a times in my setup, it is very difficult to convince the patient always for an awake craniotomy. Very difficult, because they don't agree with it. Many a times the anesthetists don't agree. So good, wonderful techniques you have shown, and multiple bypasses you've given how to do it and how to do it. Of course, Professor Zhu is a master of bypass surgery. I don't have to say much about it. There's nothing much more to comment. He has already said, and wonderful. You are doing great job, and surely your results will speak a big volume of understanding, and more people will go for it to do under local under awake craniotomy.
Thank you, Professor Harshad. I appreciate your kind remarks.
Yeah, great job.
Thank you, sir. Thank you.
I like your talk on aneurysm clipping awake. I've heard about it.
Yes.
And I was amazed, how can you manage that in awake? Because the patient moving little bit here and there, and you can rupture the aneurysm. But you showed wonderful in that lecture. Great job.
Thank you, sir.
Keep it up. Yeah.
Excuse me, Takashi, would you like to comment?
Thank you, Dr. Salem Abdulrauf. I'm Takashi Kon from Tokyo, Japan. Thank you for your textbooks. It's very informative. I'm transferring now. I move on lesson 9, final one, Japanese one. Still translation is going on. I've heard some good informative lectures about craniotomy of aneurysm creeping. This is monitoring is very important during the creeping. So this is new to me for the awake surgery for the aneurysm creeping, but it's very informative. So I will also MC giant aneurysm. I see anterior choroidal artery, and that kind of unruptured aneurysm is very important. So I've learned in a textbook and your video and contribute to the Japanese Neurosurgical Society. Thank you for the lecture.
Thank you, Professor Dr. Takashi. Thank you.
Thank you. Okay, any more questions, comments from the panelists? Okay,
John,
Go
do
ahead.
you have 2 minutes for me just to?
yeah, go ahead, go ahead.
Yeah, since Professor Benjou is here and Professor Harshad mentioned this awake thing for aneurysms, I just want to show something really quick here, just to make a point that is very important from that perspective. So if you just allow me 2 minutes, and I will just pull this up here.
Yeah. You're welcome.
Thank
No
you.
problem. Mhm.
Thank you. So I'm just going to open this here. There's an important, just one thing I want to show you that shows, why this is. We present. Let me just share my screen. So you see, this is a straightforward aneurysm here. MCA grade 1 subarachnoid hemorrhage. Okay. So
Pretty close. Later light. Okay,
because
great.
this is part of a study, we are recording SSCP, EEG in every patient. Okay. That's part of the study. So let me just explain to you. So this is a left sylvian fissure. This is the aneurysm here. Standard situation, wide neck aneurysm, small wide neck aneurysm. But this case shows the point I'm trying to make here in a second. So I'm dissecting this aneurysm, as I said, is a grade 1, okay? And let me go here. I'm getting behind the aneurysm. Those are the M2s, M2, 3 M2s, and that's the M1 here, okay? Just in general, I don't use retractors, but that's a preference of the individual, all right? So let me demonstrate what the issue is with the awake versus general anesthesia here, okay? So this patient is awake, I'm talking to him, everything is going fine. Now, because this is a thin aneurysm, thin wall, wide neck, very thin wall, I decided I'm gonna put in a temporary clip on the M1, okay? Because it's safer in a ruptured aneurysm in this situation, all right? So let me show you what happens here.
I think it's Carrie. Excellent.
Okay. So now I put a temporary clip on M1.
Carrie. Excellent.
Standard protocol. We put a temporary clip on. We test clinically. This is the right hand, the patient, and we test EEG, SSCP at the same time. We put a temporary clip on. He's automatically, this is a gold test. He's squeezing just fine. And EEG, SSCP and MAP is normal. Okay. Now watch what happens.
Everybody, okay?
I'm talking to him, he's doing fine. This is in real time. I'm reshaping this aneurysm because it extends all the way back. I'm reshaping the aneurysm. The patient is doing fine, okay? I need to reconstruct the aneurysm to kind of clip especially this dorsal wall aneurysm, part of this aneurysm back here.
Fingers here. Can you move these fingers?
Within 20 seconds, the guy says, I cannot move my arm, doc. He cannot move his arm at all, okay? He says, my arm feels very heavy. I say, okay, squeeze your arm. He said, I cannot. EEG, SSEP, MEP, totally normal, okay?
Can you move these fingers, Carrie?
I say, give me the temporary clip remover right away. The EEG, SSEP, motor mean nothing to me at this point because this is a real test, okay? That just means it's false negative, okay? So now I remove the temporary clip. I say, okay, I'm gonna finish. I'm gonna just do reconstruction here, and I'm gonna reconstruct the aneurysm.
Right here.
See, within seconds of removing the temporary clip, he's moving his arm. SSAP motor evoked potentials were normal. If I had continued this surgery with a temporary clip, the patient was under general anesthesia, I would not know. And he would have woken up with a stroke because I would not have known. So these are the little things that make a difference in certain cases that we do not know while the patient is asleep. So that's really what I was trying to, the point I was trying to make. You know, so that's, and especially true, I mean, we don't have time today, but especially true for basilar tip aneurysms, because for basilar tip aneurysms, there's no technology that that can tell you motor evoked potentials. SSP can tell you nothing about the basilar artery. The only way, and someday when you have a lecture together, I'll show you my experience in the basilar apex, how certain patients within seconds cannot tolerate it, and certain patients can tolerate 5-10 minutes of basilar artery occlusion. You do not know that. This is why when you look at the series of Charlie Drake and Ghazi Yashigo, there's a subsegment of patients who died or went to coma, but we have never known why, because they did the same exact thing that they did in every case, and they didn't know. I talked to Professor Yashigal about this. They did not know. With our experience with the Awake Now, we know now. We have answers about areas we have not known about in the past. So we are figuring out things that are unique. And I thank you, John, for giving me the extra few minutes.
Oh, thank you. Ben, do you want to comment on what he said or did?
Yeah, that's very important. You know, I totally with Professor Salim, and actually in this segment, normally the MEP-SCP was not so reliable, and we have around 12% of this kind of segment giant aneurysms have some complications.
Yes.
Yes. So maybe I will try the Awake surgery.
I will send you an email. Professor Ben will collaborate in the future.
Okay.
I look forward to
No
collaboration.
problem.
I respect your work a lot. What you have done
Okay.
in bypass surgery. I have a lot of respect for you. Okay. And
My
thank
pleasure. Thank you.
Professor Prashad for your kind comments.
Mhm.
Okay, very good.
Professor
ahead.
Salim, can I ask you one question?
Go ahead.
While you are dissecting this MC aneurysm or any aneurysm in awake craniotomy and it ruptures,
Yes.
how do you manage in awake?
Yeah, this has always been asked of me, and the answer is exactly the same if the patient was under general anesthesia. So we have 3 cases of ruptures during awake, and not a single case we had to intubate the patient. We control the bleeding. We do the same thing we would do otherwise. Really, for me, it makes no difference whatsoever. But someday when we do this lecture, I'll show some of that, and I will explain it live. When we have time someday, I'd like to show that for sure. Thank you.
Wonderful talk. Wonderful.
Thank you, sir.
Wonderful.
Thank you.
Lot of
Okay. Okay.
lot of pulse of wisdom.
Thank you. Okay, thanks everyone. Thank you very, very much, Dr. Abdulrauf. And Thanks everyone for participating, and we'll move on to the next speaker. Wan Li, are you disposed?
Yeah, okay, I
you-
can do it. Yeah,
Go ahead, Wan Li.
sure. Thank you. So, okay, thank you, John. Thank you, Dr. Abdulrauf. You're very welcome to visit China again in the future, since now the COVID-19 is over.
Yes. Yes.
Okay. Yeah. So thank you again. So, let's move to the next speaker of today's webinar, Dr. Chen Yu. He's the neurosurgeon from Beijing Tiantan Hospital, Capital Medical University, and today he will talk about some rare disease in neurosurgical practice. You know, our Tiantan Hospital, we have quite a large of neurosurgical procedure every year, and we just summarize our data bank and wish to introduce our experience for some rare disease for neurosurgical practice. Okay, Dr. Chen, you can start. Thank you,
Okay.
Dr. Abdulrauf. Okay.
Yes.
Okay, hello everyone. This is Dr. Chen from Department of Neurosurgery, Beijing Tiantan Hospital. This is my pleasure to bring the topic of rare disease in neurosurgery here today. I recently contracted COVID-19 for a second time, and my throat is uncomfortable. So please forgive me if I cough or clear my throat. I will discuss the following aspects. First, an overview of rare disease. Rare disease, also known as orphan disease, no stranger to us. It has been more than 9 years since the LS Ice Bucket Challenge, which suddenly went global in 2014, put the spotlight on rare disease such as ALS. Major countries and organizations in the world have different definitions for rare disease. In general, we can define a rare disease as a chronic, progressive, and life-threatening condition with a prevalence of less than 50 per 100,000. In contrast, the management of rare disease in China is relatively sluggish. In 2018, China began to manage rare disease in the form of a catalog list with a total of 121 rare diseases. There are more than 7,000 known rare diseases in the world, affecting 260 to 450 million people worldwide. And China currently has more than 1,400 known rare diseases, with a patient population of about 20 million. In terms of treatment, only 5% of rare disease currently have effective treatment. At present, the dilemma in the treatment of rare disease mainly has the following two aspects: lack of medicine and inadequate medical care. According to the 2020 China Rare Disease Comprehensive Social Survey, nearly 70% of medical workers think they are not familiar with rare disease. The China Alliance for Rare Disease reported that it takes an average of 4.26 years for rare disease to be diagnosed. Now let's focus on rare disease in the CNS. Among the 121 rare disease listed in the first rare disease catalog released in China in 2018, there are about 30 diseases related to the nervous system. Unfortunately, the vast majority of these diseases are not diseases that can be cured by neurosurgery. Now let's focus on rare disease in neurosurgery. First of all, let's look at how ChatGPT answers this question. When we ask it to list a rare neurological disease that can be treated with neurosurgery in less than 10% to 100,000 people. We can see that many of these diseases it listed are correct, but some are wrong. This is an interesting software, but it still need more data to train. From the perspective of prevalence, we can see that most cerebral vascular disease, brain tumor, and other diseases are belong to category of rare disease. Here, I will briefly introduce some typical cases. First, cerebral proliferative angiography, abbreviated as CPA, is a rare and special cerebral vascular malformation. Its main feature is abnormal dilation, deformation, connection, or missing blood vessels, which need to be distinguished from AVM. Its clinical manifestation are main epilepsy and ischemia system. Bleeding are rare, but once bleeding, the risk of rebleeding is very high. The imaging findings were mainly diffuse reticular vascular mass mixed with normal brain tissue, no obvious dilated feeding arteries, no obvious dilated draining veins, a large range and no obvious boundaries. As can be seen from the typical case on the right, the nuclear magnetic perfusion showed prolonged TTP and reduced CBV in the cortex far from the lesion, indicating hemispheric ischemia. Therefore, most patients start with epilepsy and ischemia symptoms. In terms of treatment, symptomatic treatment, indirect revascularization, targets embolization of the rupture risk factor, and stereotactic radiosurgery can be used. From the typical case on the right, it can be seen that after indirect revascularization, the abnormal proliferative vessels in the lesion area are significantly reduced. Significant corrosion of abnormal vessels mass also occurred after the radiosurgery. The second, stage Weber syndrome is a rare neurological and skin disorder. It's usually occurred in infancy or early childhood. The main feature includes cerebral vascular malformation, cutaneous hemangioma, and glaucoma. Image finding include gyral calcification, leptomeningeal enhancement of normal blood vessels on the brain surface, cerebral atrophy, and MRI empty vascular flow. Clinical treatment is mainly symptomatic treatment, including drug treatment for epilepsy or surgical resection, laser treatment for facial vascular malformation, or facial plastic treatment. Third, HHT. A main feature are dilated capillaries in the skin and the mucous membrane, and the malformed blood vessel in several organs. Its clinical manifestations are mainly capillaries, hemangioma, and pigmented spot of skin, central nervous system lesions such as intracranial hemorrhage, and so on. The treatment of HHT is mainly symptomatic treatment, such as drug labor pains and laser treatments of skin lesions. If bleeding occurred, it can be treated with surgery. Fourth, infectious aneurysm is a fragment abnormal expansion or expansion of intracranial artery due to local weakness or structural damage caused by infection. which can be divided into bacteria or fungal. The clinical manifestations are often not specific, such as irregular CT shape, blur edges, uneven internal density, annular enhancement after nuclear magnetic enhancement, incomplete internal filling, mural thrombosis, and lobulation can be seen in the DSA. In terms of the treatment, some aneurysms can spontaneously shrink or disappear after anti-infective treatment, and surgical clipping or endovascular embolization can also be taken, but it should be noted that it is easy to relapse. 5. Mirror aneurysm are mutually mirror symmetric aneurysm that occur in both intracranial arteries with the same name. Most of them are located in the bifurcation of vessels. In the treatment strategy, simultaneous clipping can be adopted, or and the contralateral aneurysm can be treated in the second stage, or endovascular embolization can be performed during the single stage procedure. 6. PNSH, indicating SH with blood located around the middle brain and unrelated to aneurysm. It can be caused by rupture and bleeding of peripontine venues and capillaries. About 80% have good outcomes. In terms of treatment, symptomatic treatments can be taken for PNSH, and for more serious patients, minimally invasive surgery and craniotomy can be adopted. 7. CVST refer to thrombosis that form in the intracranial venous sinus and its branches, often with insidious onset, repeated attack, and high disability and mortality. The main feature are a headache and increased intracranial pressure. Other neurological symptoms, moreover, are more common in child and young adult. The injury of vessel wall, slow blood flow velocity, and abnormal hemodynamics may be the inducement of CVST. Clinical treatment mainly include conservative anticoagulant therapy, interventional thrombolysis and intravenous filter placement. At AVMs is the main cause of hemorrhagic stroke in adult, young and middle-aged patients. The registry of multi-modality treatment for cerebral AVM in mainland China established by the cerebral vascular disease team of Tiantan Hospital, focus on creating an individualized optimal management strategy for cerebral AVMs, and make a series of exploration in risk certification and treatment decision making. In addition, there are various other rare types of cerebral vascular disease. In terms of the brain tumor, the WHO released the classification of brain tumor in 2016, and a review of rare low-grade brain tumor was published in a 2019 article on neuro-oncology. Based on this, I will briefly list 3 rare brain tumor mentioned. First, DLGMT is a glial neurotumor with extensive growth of leptomeningeals with low malignancy. Imaging showed extensive extensive peer enhancement and syncing. Due to the low course of the disease, chemotherapy and radiotherapy can be adopted. Second, GS is a grade 4 glioma. It's composed of both glioblastoma and sarcoma cells. The main treatment is surgical resection, followed by radiotherapy or chemotherapy. The outcomes is poor. The median survival was 6 to 15 months. 15 months, yeah. Third, PGNT is a mixed low-grade neuroglioma associated with seizure. Image results show that most of them were located around the ventricles. Surgical resection can be used to treat PGNT, and the recurrence rate is low. There are many other rare brain tumors, and I will not list them all. In addition, there are many developmental malformations. First, the Danny-Walker malformation, also known as the false ventricle foramen occlusive syndrome, mainly presented with hydrocephalus and cerebellar symptoms. Treatment includes simple cystectomy, lateral ventricle shunt, or cyst shunt or double shunt. The second type, intracranial fetus, also known as parasitic fetus, is thought to originate from an unsuspected blastocyst. In this case, the conjoined parts developed into the forebrain of the host fetus and wrapped the other embryo in the folds of the neural plate. Parasitic fetus is distinguished from teratoma by the young age of the patient and the presence or absence of vertebrae or internal organs. Finally, let's look at the development trend of rare disease. At present, we can see that the location of drugs, capital investments, and the application of new scientific and technology force are helping the rapid development of rare disease research in China. Finally, I would like to say that from the perspective of doctor, we can promote the diagnosis and treatment of rare disease by raising disease awareness, stressing scientific research, and make full use of social management media. We should promote scientific research needs through clinical needs, and push back clinical research through scientific research. Thank you for your time.
Wan Lee? Are you there, Wan Lee?
Yes, yeah,
Okay.
yeah, I'm here, yeah.
Okay.
Thank you, Dr. Chen, for your talk. Actually, I think Dr. Chen gave a comprehensive introduction about some rare disease which can be, some of them can be treated by neurosurgical operation, and some others may be still a difficult problem. So we just wish to tell you that there's some disease. Maybe we can find a better way for a better treatment. Yeah, and that's all. So are there any problem or question or comments from the audience?
Hello.
Yeah, I have a comment. I'm not really qualified to comment on neurosurgical matters. However, I feel that rare diseases has a place using Zoom. because it's perfectly set up. People all over the world can communicate. If we're thinking of doing that, creating a page for a certain rare disease in Zoom and having people in the worldwide community communicate with that Zoom, as well as doctors that specialize in that field. But we'll keep you apprised of that situation, developing TV stations for rare diseases. Okay, any more comments on Dr. Chen's?
Dr. Chen, thank you for your review and the introduce of the rare disease of neurosurgery. But you ranks AVM and moyamoya disease as a rare disease. I don't think it's because you even rank some mirror aneurysm and infectious aneurysm into the rare disease. Actually, in the cerebral vascular disease, regarding the cerebral vascular disease, aneurysm may be the most common. And in China, at least, in our department, I think the moyamoya ranks the 2 or 3rd. In our department, it can rank 2. And AVM was also not very rare disease. I think you mentioned the cerebral proliferative disease as a rare disease. I can agree, but you rank the AVM or moyamoya as a rare disease. I don't think so.
Yeah, I just from the perspective of prevalence of the disease. From the prevalence of the disease, we defined the rare disease as less than 50 per 100,000. Maybe a lot of AVMs or moyamoya disease went to Huashan or Tiantai Hospital, but from the nationwide, we can maybe there are a lot of patients have not been diagnosed. Yeah, I think if we concentrated on the skin of AVMs or moyamoya disease, we can find more patients.
So if you use this criteria, you should also rank the spinal vascular disease into it and the DAVF, dural AV fistula, into this kind of rare disease.
Yeah, DAVF,
Yeah.
if we use this definition, and DAVF is also a rare disease in neurosurgery.
Okay, thank you.
Okay, Harsha, do you want to comment?
Yeah, nice compilation of the rare diseases. I agree with Professor Binzu with all these comments. Wonderful. Even the venous sinus thrombosis we see very often, especially in my country, and we don't find it rare to see. And the Dandy-Walker syndrome we see very often, very often. So we don't include that as a rare disease. And I believe in Dandy-Walker syndrome, you do some cystectomy. What are the cases you do cystectomy in Dandy-Walker syndrome?
That could be a tough one to answer.
No, because I'm not aware about Dandy-Walker syndrome and doing cystectomy. I heard you, if maybe wrong, I heard you wrong. Is it true?
Did you
Yes,
hear?
I agree with you. Even the paramidbrain subarachnoid hemorrhage is quite often, ranks subarachnoid hemorrhage is maybe the 3rd largest reason for the SAH. So it's quite often, not so rare.
Yes.
Takashi, would you like to comment? We can't hear you there, Takashi. Can't hear you. Can't hear you, Nakashi.
This is a Sturge Weber like this.
There we go. Okay.
Yeah, I'm Takashi Kon from Tokyo, Japan. Thank you for the good lecture. Sometimes I encounter Sturge Weber or some rare disease, but since the experience is very few, so I have no idea to how to manage. So I learned a lot from your lecture. Thank you. Appreciate it.
Okay, very good. Any more comments, Juan Lee? Before we close?
Yeah, actually, yeah, I think just as Dr. Shi said, there's some bias about the definition of rare disease. If we think about the incidence like less than 50 per 100,000 population per year. So most of the neurosurgical disease, they are kind of rare, but for the large neurosurgical center, many patients just come to looking for treatment. So for some large neurosurgical center, large hospital, so maybe we think that they are not such kind of rare, like AVM, like Moyamoya disease, even different kind of brain tumors. So yeah, that's what we just want to give our audience a general concept about what we can do right now, and maybe what we can do for the future. Because for some rare disease from of some other organ, scientists, clinical physicians, they are working together, try to find new treatment to cure, like different kind of antibody or tumor vaccine, something like that. So yeah, that's what we thinking about this topic. Yeah. Okay. Okay, I think today we have two nice talk. Especially we invite Dr. Salem Abdulrauf to give us a nice talk about bypass surgery, especially the awake surgery for bypass. Is really amazing. Actually speak frankly, we never do such kind of surgery. I mean, awake surgery for bypass. We tried some awake surgery for other kind of vascular disease like AVM surgery, aneurysm surgery, but not bypass surgery. Maybe we can, try to learn more from Dr. Abdulrauf and try to do similar surgery for more
Thank you, Professor.
experience.
Thank you. Thank you.
Okay, thank you.
I look forward
Thank you.
to
Maybe we can invite you to visit China and maybe do some live surgery demonstration in our hospital.
I would love to do that. Yeah. Thank you.
Yeah, you have Professor Zhao Jizong and the Xiao Xinru, many Chinese doctor very well. Yeah.
Yes.
And we also had visit your hospital. I remember that's maybe 10 years ago. Yeah.
Yes,
Okay.
for sure. Look
Great.
forward
Okay,
to
thank
future collaborations. Thank you so much.
Thank you again. Thank you. So, and also thank you, Dr. Chen from Tiantan Hospital, to give us a general introduction about the rare disease. Okay, I think that's all for today's the webinar.
Yeah,
Thank you again.
Thank you.
Thanks. This is how it works. East meets West, and we educate. This is great. Thank you very much. And
Thank you very much. Thank you.